Well, welcome to our Deep Dive Pediatrics session. My name is Kate Donovan. I'm the Clinical Director of Innovation at Boston Children's Hospital, and I couldn't be more thrilled to be here with my co-panelists, if you will. So I'm going to ask them to introduce themselves. We'll go down the line. I don't know which way are we going to start. You want to start, Henry?
Okay, my name is Henry Xiang. I'm a professor of medicine. I'm the director for pediatric trauma research at the Nationwide Children's Hospital. Our team are doing research in the area of acute pain management, and also we are trying to create virtual reality for chronic pain management among pediatric patients.
Good afternoon. My name is Jeffrey Gold. I'm what's called a pediatric psychologist, and I've worked at Children's Hospital Los Angeles for the last 22 years, and also University of Southern California, where I'm a professor in anesthesia, peds, and psychiatry at USC, and have a bowel-behavioral pain lab where we investigate VR, AR for acute pain management, procedural pain management, and then also integrative medicine practices. We have some awards funding integrative care for hospitalized patients, including acupuncture, massage, yoga, mindfulness, and biofeedback.
You're up, my friend. She doesn't want to give the mic up. That's how it rolls there.
Asher Marks, I'm a associate professor of pediatrics at Yale University, director of pediatric neuro-oncology, as well as the adolescent young adult oncology clinic, which led me to run into Kim after working on some VR-based support groups for our adolescents and young adults with cancer. Our relationship has grown into the formation of XR-Peds, which is a lab within the Center of Immersive Technologies in Pediatrics, which we also co-founded.
Yeah, what he said, I'm the other half there. Kimberly Hefia, I'm an assistant professor of pediatrics. My background of the last 15 years making my PhD's in health behavior education psychology. So I've been creating video games actually since about 2009, 2010. And about 2016, I found VR, AR, thinking about how we can move some of the work, the skill-based work we've been doing with video game interventions into that space. So along with Asher, we've just been moving forward hard. We've got about 10 to 15 projects going on at any given time in our lab, all across the board. But our main focus is kids as the end user. We do other stuff, but we're really interested in how kids are engaging with the tech and how we can create interventions from the bottom up, like a user-centered design approach. Yeah.
So this session, I would love to make it with you guys asking questions as well. I have a list of questions I can ask, but this is for you. So I'll start with some of these questions here, but I invite you, don't be nervous. We're just sitting on chairs in front of you. You have a question already? I love you so much right now.
He's a Confederate.
Do you want a mic? I can run over. You want a mic?
If you like for a recording or anything else, but I can say. So Thomas Hutchinson's last talk from an administrative point of view of how effective VR is in patient care. I think clinicians are on board. Sounds like administrators are on board. Patients love it, but coding and insurance is a long way away. And pediatrics is even harder by state by state. What do you see the role of companies, of the startups that we see in the ecosystem, and what's the crawl, walk, run path to monetization and supporting clinicians?
You have ideas. I know you do. I know you have ideas. I'm handing it over to him because I can hear his brain is oozing on my jacket here.
I mean, I think the work that we have been doing is fundamental, right, for moving the needle. I have some examples actually out of Boston where they put in place an intensive inpatient pain therapy program, but that team went to the insurance brokers and brought them the data and had those heart-to-heart conversations about what they could do for the insurance brokers. And to some extent, I feel like that kind of intervention with our community would be smart, that both scientists, clinicians, and even startup companies could sit at the table with the brokers and have these discussions to explain to them through the data, the evidence that this is cost savings, if you want to talk about it that way, that it is better for patients, it's better for families, it's better for length of stay, hospitalizations, return visits, things. I think that they're not going to be reading our literature, and they're not going to be exploring ways in which they're going to be spending money. So I think to some extent we have to bring it to them. That would be my first thought right off the top. And that's a hard thing to do, but I think that would be very effective and much more time efficient than would be waiting around for the Blue Cross Blue Shields or other PPOs to come to us, because I don't see that happening anytime soon. The only thing I will say, and some of us have already talked about this today, is that we do have a Category 3 CPT code that was recently passed in January of 2024, or 2023, I'm trying to remember what it was. And that enables us to be evaluated. People are assessing what does it look like to use VR for procedures, and then the CPT organization in the United States will be making some sort of determination within 5 years about what that looks like. I just think it's a longer road, but at least the ball's rolling. At least there is a CPT code for VR for procedural pain management, and that was put in place by a committee of people, some of them that are here today. So that, again, it's kind of coming from it at a bunch of different directions, but we can't be passive about it if we really want to see some kind of change.
Yeah, I want to add to that. I was told, if our VR do not get FDA approval, we're still in that research domain. So we really encourage people to work together with FDA to get approval. Well, which means if you have an FDA approval, that will move from the research domain to the clinical domain. That's the critical step. Another step is, I agree with Jeff, so as a group, we need to push to get more CBTR codes, the reimbursement code. The current one is for chronic pain management, but there are other, the code could be expanded to include VR for pediatric acute pain management, VR for pediatric rehabilitation, VR for depression, VR for stress management. I think we need all these kind of codes. Third thing I want to say, I talked in my talk is, as a group, we need to build rigorous scientific evidence. There's so many excitement over there. Yeah, that is great. But, when it's come to the insurance company, FDA, and other mainstream scientific fields, they will say, show me the scientific evidence to show this is very helpful. If we do all this together, so down the road, I think this will be reimbursed by the insurance company, because you do see the significant impact on the patient outcome, on their satisfactions.
I guess the one thing I would add to that is I'm not content waiting for reimbursements or for FDA approval. I think that there are ways to be clever about incorporating VR into our standard of care, and expressing that ROI sooner rather than later. Otherwise, I look around. There's so many VR startups. None of them are going to survive. For insurance companies to finally reimburse for it. So you've got to find ways that it improves care and reduces costs in the hospital. Administrators are willing to listen. The one example I have is the project I've been working on the longest, which is support groups in VR. Those groups never would have gotten together if we didn't have the VR option. So the way that I explain it is, this is a tool to deliver care that we wouldn't be able to deliver in any other way, but we can still be reimbursed. It's still billable as a telehealth intervention.
Now the question, do you want to add to anything? She has add. Please hold.
Well, I'm not involved in the clinical part of in codes. I don't have to deal with that, but I'm on the horrible end of prevention. So the work I do is on prevention with substance use prevention, HIV, STI prevention with teens in schools. So yeah, no business wants to fund prevention, especially kids. And so it's important work, and in the long term, there's a long-term benefit, right, with prevention, even if you can delay kids a year or two in some cases, but nobody buys in. Yeah, it's hard to get any prevention funded at all.
Agreed.
Doesn't stop me, but...
It doesn't stop any of us, obviously. We just push ahead. We'll do it for free, whatever. It's all good. You had a question.
Yeah, actually, a comment and a question. Most of the time what we see in the literature usually small studies, small sample size studies, because of money or because of other reasons. We don't have, like in my country, we don't have like many programs, research programs for pediatrics. And I was wondering if it's the same thing in the U.S. Does the NIH or other agencies have specific programs for pediatrics research, or you're just like us?
Who wants to start with this one?
Well, I can say Asher and I have been working on a scoping review for 2 years and we're looking at the use of VR in pediatric population using headsets mostly. And yeah, there's not the studies are small. They're feasibility, acceptability, some small pilots, pre-post pilots. They're not anything to write home about. But if you think about how early we are, VR goes way back. It goes way back, right? There's a lot of it. Some of us have been working on it for decades, but the majority of us have not. So when I think of it as a field, we're a young field in research, and where research moves slow and technology moves fast. And sometimes when we're doing these projects that technically take 5 years to do a good solid RCT in the appropriate way with enough participants, the thing is, by the time you're done, it's antiquated headsets, and it ends up knowledge that a lot of the pilot studies already kind of figured out. But it doesn't mean we shouldn't do the research, and we still need to fight for it. I feel like we're just still so early in the game that I think we're going to start to see it. And I was really excited to see the talks or the section yesterday with research and the importance of conducting research in VR, and I thought that's a good first step that we need to all be thinking about. But I think we're just so early into it.
Sure. Okay. So back in early 2000s, when I was writing grants to NIH, right, they got rejected all the time because they just thought it was lunacy, right? VR was pure lunacy. And so, but what I see now, because I'm on a number of study sections and I get asked to also be a reviewer for other granting agencies around the country that are more foundation-based, you see VR studies coming in, and they're being looked at more favorably today than they used to be. So I think it's, as was mentioned, we're in the nascence or infancy or toddlerhood of the development, even though it feels like for us sort of long veterans that it's been going on for decades, it's really still early. When I started seeing Oculus commercials on television, I was like, wow, look at this. This is crazy talk, right? It's on regular television kind of thing. So it's really come a long way in a short amount of time. So NIH has a number of branches that focus on children or that focus on integrative health or focus on substance use. So like NIDA, for example. And in all of those spaces and more, there are spaces to submit grants for virtual reality. Because virtual reality has so many applications. So substance use, anxiety and mood conditions, integrative health. So the NIH body as a whole is accepting more and funding more VR than they ever have before. So there are mechanisms.
Yeah, I may have a little bit different opinions about this. I think it's our responsibility as a leader here to aim for large multi-site study, even across the board. We already have a lot of pilot evidence. We are ready to do these multi-site studies and involve multi-site together to increase the sample size. There's a literature review by, there's a good Cochrane literature review. All the sample size so far we have said they have less than 50 participants in their intervention group. And what they aim for is around 200 participants, which means around 100 participants in each arm. So, but if we say, okay, we are not there yet, you will not be there yet. It's our responsibility to say, how can we aim big and aim high and then put together a multi-site studies, there are money there. It's just whether you have a rigorous, outstanding grant applications, and then you show you provide evidence to the study sections and leaders to say, we already say this was effective. And then, we show them, we need these multi-site studies to provide more rigorous science. That's my a little bit different opinion than two other panelists.
I agree with that too, but I think also not only do we need to do the large RCTs, the multi-site, but I think we need a different approach to our methodologies. I think we should be doing more hybrid designs, more, we're doing controlled trials but with implementation, and you've seen more models that are more up to date. I think the RCT, the idea that we start with a technology and we can't change it or adapt it or anything until we've finished a study, and then we go back and then we get another grant to implement that, and then then we have to come out with those results. I feel like we've got better models now and better approaches to research that we can be thinking about that along the way, so we can implement, we can make changes, and we can get to the end and have a sustainable product that we know is going to go out there. So I think it's a lot of things that need to change. RCTs generally aren't the best when we have technology like this.
That you give an excellent point with that. I mean, going back even to the internal review boards, I remember just walking in because they would be like, no, I'm not going to use this VR headset. What are you talking about? Here, put it on. Oh, this is cool. I can see this working. So, you do your little road shows with that, and I'm sure everyone has done that because it's still a really difficult thing to explain to people. You have an add-on.
Yeah, but I don't want if someone else wants.
He's going to ask a question, too. Do you want to wait?
Yeah.
Okay.
So I'm thinking an alternate approach to funding for these sorts of research and projects, and even just the care for the patients as the methods are established. I would imagine something sort of like a hacker space for VR. Would it be like in this vicinity, right? Would be a great resource to collaborate on not just being able to provide for the needs of research and hospital patients, but also you'd have this space where people in the public could maybe pay a subscription, come utilize the space, come experience different headsets and different games. I myself, I do a lot of my workouts in VR now, so I'd pay a monthly subscription if I could go into a little space, have 8x8 space to just do a little bit of workout after work before I go home. I feel like that sort of an approach, that sort of an innovation would just be multifaceted and be able to cover a lot of the gambit of the varied needs in business on these lines.
I am the co-founder of Hacking Pediatrics out of Boston Children's Hospital, and actually went to Children's LA, and we did our first XR hackathon. Do you remember what year that was? Yeah, so it was then, and so there was that, and it really was a very impactful event for sure. I think the struggle from someone who runs hackathons is that scaling from the prototype to the bedside, and that's something that we struggle with internally, and then trying to figure out the IP, that piece of it as well. So I love that idea because as a hacker myself who loves to go to all of these events and just be a geek for a day, I think it's brilliant. And I love the idea of getting people from different lenses on the same problem. You explain that pain point, you're good to go.
Can I say something real quick?
Yeah.
It's interesting because people criticize VR all the time, not because of the headsets. That's really not the point. It's the software, right? We all can agree upon that. And the software changes a lot. Yeah. And so it is hard, like you were mentioning earlier, you get funding to develop something and test it, and by the time you put it into the literature, the environments have changed. So then the public or your other scientists, colleagues, or clinicians are like, well, what this new one here? Well, there's no evidence on this new one, but this old one works. So then people want to move to the new one. So it's sort of it is a quick moving target, not only the headsets, but the software. So if software is medicine, for lack of a better comparison, you don't have 72 different types of SSRIs, right? You have like 6 or 8 or 10 of them, and I think that's part of the problem. And if you land on one, like for example, Hunter Hoffman and Dave Patterson, who've used Snow World since the beginning of time, all their evidence has been around Snow World, right, and how they've used Snow World for a variety of interventions. And they haven't really veered much other than just updating the world, right? They keep using that. So that's just a problem. And there's probably solutions around that problem, but it does move quickly. And so it's hard to say to the general public or even your reviewers at NIH or a foundation or philanthropically, like they say to you, why is this world good? You know, you're like, well, because I say so? I mean, there's no evidence for it. It's like, that's not good enough rationale, and a reviewer will just squash your grant or your funding. So that's part of the problem. It's hard for us to align on what's correct as the right sort of intervention, medicine, or dose. So this is challenging. It's not impossible. I'm just saying it's a challenge that we all face as we all build worlds and we all do experiments and we try to roll it out clinically. Like the guy from Hoag who presented, I have no idea what his people were looking at. Like, I don't know what the environments were. I have no idea. It could have been 17 different environments, and he's giving the data about how good it is, but nobody really knows what they're looking at, you know? So I don't know, but that's an important part of the work that we do is trying to determine those environments.
Yeah, for sure. You guys create. Do you have any ads on that as creators?
It's hard.
Yeah.
No, I mean, I think that yes, the software gets iterated upon, but there are core elements that stay the same. You know, your graphics may improve, your hardware may improve, but the mechanics, for the most part, are similar in each iteration, and that's the effective ingredient in these, right? It's not necessarily graphical fidelity. It's the mechanics, and what is that doing to the user? How is that hacking their brain? And so I think one of the biggest issues is that those reviewing the grants don't understand a lot of the very basics that we take for granted. I sat on Yale's Institutional Review Board in their Cancer Center when my grant went through to do these support groups. And I was used to sitting on that board, seeing these phase 1 drugs come through with side effects that are like insane, all of them including death. And they went through IRB in 15 minutes. Mine, where I said I wanted to get a bunch of kids in a circle and put on VR headsets, that took 9 months. Because they just didn't understand. They're bringing in experts from all over the university to assess it. So I think there's a component of educating the public. And yeah, Meta and Apple are doing a good job, doing that, but I think we also have a role to play. And I think the more that we can evangelize when we go back home and actually explain why we think these things work. It's not about, version 1.0 or 2.0. It's the mechanics and how that's actually working. I think we might be able to get ahead.
Yeah, my IRB was the one that got approved in 15 minutes. We're at the same university. I wanted to bring headsets to 300 kids in schools. Mine, they were under 13 too. We're like 11 to 12-year-olds. Mine, and it was a VR game around vaping prevention.
Yours is so much worse.
And mine went right through. And this is the same time, and his took 9 months. So it doesn't make any sense. So yeah.
Did the reviewer have coffee this morning?
Yeah.
It's exhausting.
I will say though, like in terms of development, I think one of the things that it makes us move slow, but I think it's really valuable, is that user-centered design approach. We are at the very bottom, and we are bringing in all the stakeholders. We're bringing in the users. We have youth advisory boards. We have, every step of the way is getting vetted. And then we start with prototyping, and we make it very clear too, because everyone assumes it's going to be super shiny, but it's boxes, right? And our cubes, and your hands are boxes, and and you're in an open room. But it's really about, it's not the shiny stuff. You actually want to peel away the shiny stuff and see if the mechanics and that core part of the intervention you're doing is work, because the shiny stuff is just shiny. It's just shiny, right? And then if you've got that kind of base, that's good. And I think one of the biggest barriers we have is just the porting. We did an amazing RCT, 300 kids, followed kids for 6 months around this marijuana vaping prevention game, and it is dead in the water because it's on the Oculus Go, right? So now we were desperately trying to find funding to port this to the Quest 2, Quest 3. It's got great results. It's won all these awards, and it sits dead, and nobody can use it because of that. Just as something as simple as trying to port it, we can't, getting funding for that. So a lot of barriers.
I forgot about that one. That's a huge one, actually.
It is.
Yeah, I forget. We just move on, I guess.
And then you have
Do you
to also
wanna-
be sure to be inclusive too. So So like not all
Yes.
kids, especially in school, not all kids can be in VR headsets, right? So you can't go into a school with an intervention and say, everybody in this classroom can take this except for you who has vision problems or you
Right.
that has a disability. You can't do that. And so you have to be thoughtful about web-based interventions that never really port well from a VR. You know, you've got to make considerations for that, and it gets costly. Yeah.
Yeah. Is this an add-on there? Can we?
If I just wanted to clarify it.
Yeah, yeah.
My suggestion was like, you could potentially have something that doubles as like, not only resources for research, but like a community center, a VR arcade, a VR gym, all together, and be able to utilize that. Like you can inform the public, you can bring people in that would help to fund the overall institution itself. And I just think that would be a multifaceted approach business-wise.
Can we steal your business model? Yes, we got this. No, I think it would be very cool. I have someone behind you had their hand up, and we'll go to you.
I was one, so I was here 3 years ago. I'm a geek, by the way. And at that time, user-centered or patient-centered approaches derived from my zone weren't as widely used or known. So I'm really happy to see that they are being integrated, and it's great because it allows you to know more about the users and get the work accepted by stakeholders and that sort of thing. But I'm wondering, in your work with technical people like me, are you finding that we have enough medical knowledge or savvy to navigate the barriers and challenges that are inherent with
You mean like building out solutions with technical partners? I just had an experience with Apple. Is anyone from Apple in here? I'm going to get. Do we go straight to industry? No. This one we had an opportunity to build out on the new Apple Vision Pro. And I'm speaking as a moderator here, I guess. Sorry. Let me hack this whole thing. And there was a physician, actually, who introduced the device to us as if it was the most magical thing ever. He had white gloves and everything. It was really cool. I was like, okay, this is happening. Absolutely no. I would say hard no that they don't have that medical background. And it was really tough because we had to build out specifically on Xcode and Reality Kit. We couldn't use Unity or anything else. So all the things that I knew how to do in every other headset, I no longer knew how to do in their specific things. So we couldn't actually execute some of the ideas we had because of that. And because the device was so new, again, no disrespect to Apple, this is brand new and we had the luxury of being able to build on it. They just didn't know, they couldn't visualize what we wanted. It's brand new in their space. So for me to say I want to have the crown just ease me into a simulated environment with noise to distract my end users, they were like, yeah, I don't think we could do that. Well, you have to. I see it on your device already. Who's building that? Where is that person? So I think that's been my experience, and I'm using Apple just as the person there. But you guys build yourselves, so for the most part.
Yeah, so I mean, I think at this point we've got a process down, and we've got the people that we work with, and we kind of all know our roles, if that makes sense.
Do you have to train them?
No, so the way that we see it is our role is to provide that knowledge. They don't have that knowledge, and I don't think we expect them to. You know, they are, we work frequently with preview labs. We've worked with some other collaborators as well. I work a lot with the Glimpse group out of New York. They help me do a lot of the social VR stuff. But we've got an established relationship where I can give my input, they can tell me what they can and can't do. When these relationships first started, it was much, much harder. So for example, when I first went to Glimpse to do the support groups, they had their own vision, right? They wanted these support groups on the moon or on the roof. And it was just complete sensory overload, and we had to kind of scale them back. So it's a relationship.
I'm asking because we're building a new medical school at my university, and I'm trying to build bridges there and see what the actual need is for training technical people to be able to participate in deeper ways in health tech in general, but VR specifically.
I do think there's a benefit to that, though, to have that person's not in the space, because they will bring ideas that you never thought about. That's part of the fun of hackathons. So I shared my experience with Apple because I had higher expectations where I was working with a physician that couldn't get the vision. But I think from being able to build solutions out, 100% having that lens to be able to say, have you ever considered, which medical people wouldn't do that. So.
Yeah, I think, at Anschutz, which is the medical school right behind Children's Colorado, they have a really pretty digitally savvy set of labs and whatnot. So they might be a really good paradigm or model to just go sniff around and see what they're doing, so that you can inform the build out by you. Because they're pretty connected, and I think they train and educate their physicians who are in training to think more digitally, which will be like that's the proper bridge.
Yeah, I would say multidisciplinary approach is needed for this kind of research, and you do want to engage other people. And I like the idea. I'm fortunate that Katie left, that Nadine just left. The co-design and co-development engage those end users into this, and also we have to be you must to have a visionary leader there to say here's the vision there. And also you think big, and also this leader must be also a little bit humble. But for example, we are involved all this kind of mechanisms. So we have this VR development, we have all these psychologists, and we all have this biostatistician. Nobody can be an expert in all of that. But you have to have a leader to say this is the vision, and the leader got resources together, and then listen to all other peoples, and everybody will make significant contribution to the success of the project.
Just going back to this content, and then there's the headsets. And as experts in pediatrics, so like TheraVR, we just launched our new MVP, and we're in telepsych, right? So it's telemedicine. But one of the things that comes up is about the headsets. What is your opinion in terms of the appropriate age using, so we have Oculus, we have Pico, and we have HTC. The Elite headset is the lightest headset on the market. So in your expert opinion, and I'm all about patient safety, qualifying for VR, but also the headset for little guys, right? What is your expert opinion on what is appropriate in terms of their age and the cutoff? Especially like if it's comorbid diagnosis, if it's cancer or mental health. Do you have any thoughts on that?
Aren't we supposed to say we're device agnostic here? We're device agnostic. What are your thoughts?
Well, we did this. We talked about this earlier, but I think there's a lot of factors that go into it. But headsets were developed for adults. The controllers, hand tracking, it's adult hands. So a lot of it has to do just physically. Headsets don't fit right? When we talk about that IPD, right, that their eyes are too close together. For really little kids, they're not even really they're not even seeing well. They might not be seeing an image clearly. Then you've got a lot of cognitively, they may not understand how to navigate spatial environments. They may have trouble with distinguishing between the outside world actually exists when I'm in VR. I mean, there's a lot just to consider where kids are, and all kids are different. Generally, we say, this is just kind of when we're talking with experts and building out kind of these kind of starting guidelines, but we would say under 6, probably not a good idea to put them in headsets. There are always, as Asher always says, there's cases where if benefits outweigh the risks, then that's different. It's kind of case by case, but generally younger kids, young kids, we just don't want to see them. And I even see in an industry like Oculus is recognizing this, or Meta, Quest. The Quest 2s and Quest 3s, they've moved this down to age 10. The Quest Pros, they say age 13 because they're heavy. And they're like, this is not good for kids in the neck strain, and they're too big. So it is interesting that even device specific, even if we want to be agnostic, there is differences between headsets too. But it's just a reminder that those headsets were made with adults in mind, not kids. And so small kids, small heads, small bodies that are just fine gross motor skills cognitively are not ready yet. So, yeah.
I
You
think a
wanna add?
financial approach of this too, from if you're in the hospital environment, is we don't have the funding anymore. Post COVID, we're in dire straits here in this space. So trying to figure out how to standardize our headsets across the board has been a challenge. I mean, you talked about your boneyard of Oculus Goes, and I think we all have a boneyard of all of these headsets. So museum. So that's something we also have to take into consideration, because we can't just, you might have a great solution, but if we don't have the headset that's going to run it, sometimes we can't be part of that.
We see your hands up. Don't worry. The what's interesting also are that companies that make their own headsets for kicks and giggles, right? They have no age requirement on them. So that's interesting. When you think of off-the-shelf commercialization of headsets, they always say 13 plus or 12 plus. But if you're a company that creates your own headset for your own programming, like for example, Smiley Scope, perfect example, it has no age requirements whatsoever. It gets back to the primary issue, two primary issues, fit and development. I think we always have to think about fit and development. If it doesn't fit right, they're not getting the right dose. And if they're too young, developmentally, it's going to not work because they're going to throw it off as they presented today, or it's going to disorient them or scare them or freak them out. So you have to think about the child's development and then that. So there's a hand here who's.
There's a lot of hands, but I was kind of having fun leaving them over there.
I know they're sweating.
They were like doing. I
They're
know
sweating
they were
over
doing
there.
like a wave. It was like one after.
Pressure because I was like halfway through. But I was just wondering about inclusion. I think Professor Kimberly mentioned that you cannot go to school and then purposefully excluding children because they have disabilities or like some. And I was wondering, so what? Because I'm very interested in the field of children with disabilities, and they're frequently excluded population from studies in pediatrics overall, and they do experience a lot of pain, frequent procedures, and I think they would benefit a lot from VR.
Our approach, I'm mostly in schools, so a lot of what we do is we think of alternative ways, like you can cast, right? It's not as cool as being in an immersive environment, right? But you can cast, you can do social experiences like with kids, like together with the casting. This is ideas that we've come up with teachers to do this kind of stuff. There's also great groups out there, and I'm thinking of able gamers that can adapt any device, any controllers for a specific kid's needs. We've even seen them where they can adapt it with moving their foreheads and their all kinds of stuff. Squeezing if they only have ability to move a finger or two, that they can create controllers just for that, so that to ensure that inclusivity. So there are ways. I think as researchers we have to think about that. You're right, and always when we're thinking, especially like bringing an intervention in, are we not leaving any kid out? And sometimes it's going to be costly, and it may take a lot of effort for just that one kid that's in that classroom or that kid, that patient. But we have a responsibility. I do agree, and there are groups out there.
And I will say one place to look for inspiration is actually the gaming community. This is a bit of a new trend, but both Microsoft, Xbox, and Sony PlayStation have adaptive controllers now, which are remarkable. They're completely reconfigurable. You can definitely hack those into a VR experience, and Sony's got its own VR headset where it work. Also, in terms of software design, I think it's also important to think about. So it's probably PlayStation Studios does the best with that. They've won several awards for accessibility settings in their games, particularly Santa Monica Studios and Naughty Dog. So those are some places to look.
Thank you. Did you want to add?
Yeah, I want to add to the content question. I agree with all of the panelists, but however, we need to think about, how do we creatively create some, virtual reality. For example, this lady talk about individuals with disabilities, but also in our field, the majority of burns happened among 2 to 5 year old. currently I only feel comfortable to recommend virtual reality for 6 and above because of this headset. However, we are exploring the opportunity to create a virtual reality for 2 to 5-year-old. And I agree with some of the other panelists that it depends on what you want to do, and then the content of your virtual reality must be age appropriate. So.
Building for pediatrics is tough, and that's whether it's for VR or you want a device. The companies that are building these need a return as well, and sometimes they're not willing to jump into the space because of it. So that's definitely something I think we all can speak to, that we've had. Yeah,
I was gonna say,
I mean, and unfortunately, the end on accessibility, if it's not going to prove them or enhance their marketing, then sometimes they say no to us, which is a bummer.
Sorry, to piggyback on the inclusion conversation, in terms of working with developers on inclusion and the software design, as we hear a lot with AI and the biases and intrinsic biases in AI, how do you see that in terms of your roles with not propagating that into the development for different racial and ethnic groups?
You want to start? Someone want to start?
Oh, they're all going to come to me. Okay, this is not helpful for you because we work together. Do you all want to take it?
I can say,
Okay, go ahead.
I was going to say,
And then I
I
can
feel like
jump
I'm
in.
talking so much. I'm so sorry. There was somebody that came in an interviewed for an assistant professor position at Yale, and she didn't end up getting hired, but her focus was bias in AI. And I was like, it was just this light that went off, and I was like, we need this person on every project. It's just like you always need to have that person. I think that's where that multidisciplinary team comes in becomes really important. Ethics too, if you can find somebody that is, an expert in ethics, we have that person at Yale too, like just bringing them on board, and because they're going to bring in a new perspective that we're not thinking about. And so that was my goal, is like trying to find this person, even though they didn't get hired, being like, please come and be a part of our team, because their expertise is going to just be so important. So I think that there are those experts now coming out, popping up more and more, and we need to find them and we need to bring them onto our teams. No exception. They just need to be a part of a team, and we need to run things by them.
Yeah, I think it really tackles the sort of transdisciplinary, interdisciplinary thinking, which means you have to have more than 2, 4, or 6 eyes around the table, right? And that's how you develop, right? So even in these game hacking scenarios, you have all kinds of people there from different cultures, different linguistic backgrounds, different ethnicities, different regions of our United States or of the globe. At USC, they've got a media program where, it's just so diverse. So you have to have lots of eyes around the table to develop the proper content for what it is that you're doing. So, and the last comment is having environments that are customizable, right? So that you can be more inclusive in ways that a single environment that isn't modifiable isn't, right? So, and I think I've always talked about the VR pharmacy, right? And then you also, for children especially, teens, 8-year-olds, 9-year-olds, they all want to look and feel and see something different to their own personal avatar or whatever. And I think that having customizable environments would be helpful in managing some of the bias that are inherent in game development. So that's another way of tackling it, is by having them be adaptable within the same environment, right? So all the same ingredients are there, but it can look different, like have different skins, like, not just skin color, different skins, different looks for the people who are inside the environment.
Just to feedback on that in terms of just like accountability, because I think we all, with best intentions, try to working with a company whereby they try to incorporate different skin tones and things like that, but then they're demoing their tool, and then they're speaking English with a Spanish accent.
Correct.
And we're like, that's not
Yeah.
what we're going for
Correct.
here. So,
Right.
just to understand those blind sides and how you
Thank you.
You've been waiting a while, my friend. See, you thought I was messing with them. I think I was messing with you more.
Really appreciate all the discussion. I wanted to go back a little bit to Asher and Kimberly's discussion earlier on the guidelines. I appreciate everything that you guys were talking about with regards to headsets being built for adults, all the components and the rationale why you had the different categorizations. And I appreciate the highlighting the kappa piece. What I'm wondering is, based off the guidelines, obviously preliminary that you guys put up, how do you prevent that being the way, like what it is, just like our age 13 was for so long, when the hope is to have growth in the industry that helps change it so we can have younger users.
Yeah, I think that's why, we gave this talk at GDC last year, and the last slide of that talk was that one with the green, yellow, red, right? I'm like, well, this isn't helpful. This is just us being like, don't do this, right? So I think what we tried to do here was add on recommendations to make it more acceptable, right? And we're all about that. We feel like it's a valuable tool, and you're actually doing kids a disservice by just saying no, right? So I think that those are guidelines for what is currently available on the market. I think that would significantly change if we started designing in a way that was kid-focused and safe and accessible.
So one of my other jobs at my hospital is I'm the IRB chair, right? And so protocols would come through, and the black box warning would be like 13 plus, and investigators would get really upset about that for VR use, myself included. And so what we did was we started to gather data from other investigators, a la to my right, and others across the country to say, well, they've been using this technology safely with no adverse events in this age group, and they have these outcomes. And so we were able to mount a case within our own institution, within our IRB, to get approval for younger patients through showing the data, which was in opposition of what the box warning was. So that's just another way of doing it. But it still doesn't address the fit issue, right? It has to fit them. There's sometimes there's larger 6-year-olds who can use the tech, or really small 6-year-olds who shouldn't use the tech because it doesn't fit and they're not having the experience. That's the issue. But sometimes you can get around those other guidelines by showing evidence. And then the IRB says, okay, that seems reasonable.
And to piggyback on that, to put it in perspective, as a pediatric oncologist, none of the drugs I use are FDA approved for kids.
Exactly.
Yeah.
Right?
Yeah.
Every
I love
time
that
I
one.
order chemo, it's like, wait, this is for a kid. It's like, yeah, what do you want me to do? Like, FDA never approved it. Nobody wants to market
None
to
of it
kids.
is. Nothing is.
So yeah,
That was kind of
Off-label.
Yeah.
Off-label.
Like,
Yeah.
off-label.
Yeah.
It's like
Everything's
there's
off-label.
plenty of medications that get used off-label and prescribed for different things.
I can't remember.
Not even considered.
Nothing.
Yeah.
medicinal.
Yeah, I can't remember the last time I prescribed an all-label
Yeah.
medication.
I'm glad Kimberly and Ashley they are creating these guidelines, but I think that's just recommendations, and then for us to pay attention to that. But that's just one of recommendation from a group of outstanding researchers, and I may have different opinions, particularly for those less than 6 years old. It depends on what we do. But as a field, if we have different opinions, perspective, we come together, and then that we will got to a point, to figure out, what's the age appropriate and what's the content appropriate. Yeah, we are not there yet.
Yeah, the content, definitely.
Yes.
You brought that up. That's
Yes.
great. Does that answer that question? Awesome.
How's your arm feel?
He was working on there, I know. But he was using the chair, I think. Yeah, so it's all good. Yeah. Any other questions? Yes.
Talking about the contents, you mentioned co-design, ultimately we're dealing with young people. They're pretty resourceful. After 20 years in child psychiatry, I'm kind of learning from them about the world, and I feel like I'm kind of looking at the world from outside in. And, they're living in a different world, that immersive world. It's something which they're shaping, they're designing. How they involve in all these projects. And I'm not surprised that reviewers can't sort of really properly
very good point. That's why I like the presentation from UK. They have this co-design and co-development. And also there's a federal funding agencies encourage you to do that. It's called engagement grant. So what we are trying to do, I'm trying to submit a grant proposal, is called engagement grant. Is basically we are thinking about develop virtual reality for chronic pain management. Okay, so I have to involve those teenagers and their family members and nurses and the psychologists, occupational therapists into the design, because if we do not involve them into this, okay, we think this will works and may not work for them. Another thing I think I have an idea is called personalized VR development. You know, we develop all this VR development. If you go to this VR development, sometimes you feel, oh, you feel the lack of the connections, right? You like the beach, but I may not like the beach. But I may like the mountains. You know, I may like my past experience of other things. What we can do is we can allow them, those users, to sort of use their experience, their tools, and their videos to create their own personalized VR. And that when they feel that engagement, they feel that connection. When they use that, particularly for those long-term use, you know, so they have to be involved, engaged, and connected for them to use that again.
I think you guys have a teen advisory committee or a kid advisory committee as well, as we do at Children's. There's not a project I do without teens and parents at the table. And I get in trouble for that all the time because I'm way too transparent about the things we're building out. But I want that lens, and I think you guys are doing the same.
Agreed. And what we do with our teen advisory boards, we actually have the youngest person on our team. She's a postgrad. She's 22. We're there to oversee her, but she's actually leading those because the teens connect closer to her. They're less likely to talk to us. Yeah, we're cool, right? But they're less likely to be honest with us. They're much more likely to kind of speak, you know, because she's a little closer to their age, and they're more likely to be more honest with her. So we've also learned that it's hard to kind of like let go a bit, but you know, she does great leading teens and getting teens to talk where they just wouldn't talk to us. But
They talk to me. I'm wicked cool. I play Legos.
You're wicked smart. You and Emmett. The other part of that really quick is that a lot of, again, just the NIH review part of the world is every one of those grants that come through, they look for community advisory board and family advisory boards. And so that's kind of become a necessary part in granting and also in just, I think, development in general, even if you're not getting NIH funding. So people are recognizing the importance of that, and I think we all do as well. We didn't think about it at first, and now we recognize it's really invaluable.
I think without it, you're going to go back to the table and redesign things. So it's also helpful for us to get them sooner rather than later before we actually build out a giant solution, a huge project, and then you give it to them, they're like, oh, what is that?
It's phase one of every project we do.
Yeah, absolutely.
Let's have a really great example. We were creating a game around HIV STI prevention for inner city kids, and this was about a decade ago. We were a video game. And we brought teens to the table, did focus groups with them, and we had, we're talking to them. And the main thing that they kept bringing up about things that would, mess up their life wasn't STIs. It was getting pregnant. That's what ruins your life. You can have an STI and have a fulfilling life. You can HIV and have a fulfilling, go to college and stuff. The thing that screws up your life is getting pregnant at 15, right? Because so you're not going to college. And these are kids that they're low SES, they don't have a lot of access to resources, and that they're kind of following in the footsteps of their family. So the game shifted. It became less about HIV, STI prevention, even though that's what the NIH funded us for it, but we made it broader. And the big storylines in there were about pregnancy, because it's still all connected, right? Using condoms and being able to talk about sex and understanding all of this. So it was still the same conversations, but those outcomes, the storylines had to be very different because it had to connect to the teens. So, and it shifted.
Can I do one more?
Of course.
I want to do one more real quick. Another great story like this. We got funded by the CDC to do a game for NICU parents to try to explain the importance of hand hygiene. And the initial pitch from the CDC was use VR and show them how to wash their hands real good, right? Like, this isn't gonna work, but sure, yeah, we'll do it. Give us the money, we won't tell you why you're wrong. So, so we got the project. We started doing our focus groups. It included parents, nurses in the NICU, infection control specialists, all kinds of stakeholders. And by the time we were done doing all this work and analyzing it and putting it together in a nice little code book, we found that knowing how to wash their hands wasn't the issue. It's thinking that they needed to wash their hands was the issue. I mean, we had to go all the way back to very basic germ theory. So by the end, instead of a game about washing your hands, we have a game about a cute little alien that you can't touch until you wash your hands and then explain why the germs spread and how they spread. So I think there were multiple times in our experience in developing games that we've been really surprised once we really got to the key stakeholders and end users.
Want to add anything? No? You have a question over there.
So a question, well, more sort of on a kind of comment. So that whole idea of inclusion on the one hand and also sort of user-centered design. So the way that we've been approaching it is we've been partnering with the school and we're sort of having interns every year, right? And I do not look at their CVs. I just accept all of them. And then on the first day, I say to them, whoever shows up, we're going to have sort of sessions 3 times a week. Whoever turns up, these are the tasks. But you get all of your hours beforehand. So you don't have to show up. Go and enjoy your summer. Go for it. Totally good with that. But if you do show up, here's some VR. Figure out if you can use Unity. See what you will do. And the results are magical.
Yes.
And it works into bias because I try to keep the camera off at all times. I just tell them to sign up onto Discord and I have no idea who they are. It's just a voice.
That's awesome. So cool.
I love that.
Right?
That's
Great
fantastic.
project, yeah.
Yeah, I'm thinking about this. So there's so many children that suffer.
Something he said, clearly.
They suffer from a chronic pain, miserable life for them. And then if we involve them in this co-design, co-development VR, there are many magical benefits. For example, they can learn of the new technologies. After they create their own VR, they have that ownership, and all kinds of these things can come from that, and we learn from them. So.
Sorry, there you go. I knew I saw her hand somewhere.
Yeah, thank you all, appreciate it. Apart from like isolating funding opportunities, how are you identifying your champion internally or across institutions or otherwise, like what tactic are you using that you think lets people find you in the space?
We hired a social media influencer, and I'm not kidding.
Did you really? Did you?
No, she just happened to be.
Okay. I'm like, wait a minute, what?
Amazing. Yeah.
It's so honestly we're all kind of academics and we're used to being very internal and sitting and writing, getting our grants going. You got to get out there a little bit though. You know, you got to talk to people. You've got to leverage the internet. You got to do a little bit of self-promotion, and what we found is they kind of find us.
It is true. I think for us too, I've been since 2016. I think got some funding from Oculus Education at the time to create this vaping prevention game. I couldn't get anybody to listen to me at the university. And then like as a year or two would pass and you would see, this is how we did it actually. It was like, Stanford's doing cool stuff. Yale, you do not want to be left behind. Because what we've learned with Yale, especially, they want to be innovative, but they want someone to do it first. Right. And then they want to
be kind of innovative.
Kind of, but they want to make sure somebody's tested the waters first. So I think we did that a lot of like really pointing out the other champions across the U.S., across within our community, within Connecticut, and just being like, these are the champions. We don't want to be left behind. Like this is not going away. VR, AR, AI, MR, it's just not going away, and we have to be responsible and be a part of that. And I think Asher and I have been really good about opening our doors to and everybody in our department, in our section, across the university, and also within the community. So we have high school students coming in, we have We have local colleges coming for field trips.
Nonprofits.
Nonprofits, we have anybody, our doors are open, and we also spend a lot of time going and talking to others. So we will go to I went to talk to some middle school students at Career Day about what we do. We're bringing our headsets to Michigan, to Detroit, Michigan, and exposing kids. Like, it takes a lot of our effort, time we're not getting paid for, but our hope is that it will pay off. Also, too, we were lucky to get over 200 headsets donated, and we've opened those up to any student that wants them, any clinician, anybody needs them for their pilot studies, whatever we can do to support that. So we try to be
Open.
yeah. I mean, we're not stingy. We really want to be helpful, and we try to. Anybody who wants to meet with us, we meet with them. It's exhausting.
It's really tiring.
But I feel like it's important. Yeah.
You get rich information from that for sure.
Yeah.
So that's the other benefit of that.
Yeah, as I grow, I learned recently that we need to have different roles. Depends on what funding source you're talking about. I couldn't agree with more. We need to go out and to promote our research. Our researchers usually think more about research, but not think about marketing and promotion. That's sort of like we can learn from the marketing groups. Second group is depends on funding resources. If you want to aim for large federal grant, you must become the top leaders in this field. Otherwise, you are not going to fund it, right? That's for sure. Third thing is it depends on whether you are talking to your senior leaders to say, I need this money. If that's the case, you need to have this business head, to say create business proposal with the good detailed, investment in and benefit analysis. And I did this before when I went to business school, got my degree, and then later on, when I present my studies, I always have this form, budgeting, analyze, and five-year investment and benefit, and then that really impressed those leaders because usually research say how good is our research and how great this project is, but on the senior leadership mind is how much money I need to invest, what benefit I got from it. So different hats when you trying to approach different people to get funding.
Yeah, I completely agree. I think it's along the lines when there's new kind of flashy technology that people's really excited about.
Yeah.
Also brings a level of scrutiny, which is warranted, right? You want to back your research, but that's why I'm curious. Like with that increased level of kind of scrutiny on untold, pathways. Like how are you guys finding success? Or where are you finding success?
Actually, I found it's easier to get money as I got more reputations, and our foundation come to me say, how much money do you need per year for this kind of research? This is cool. And this never happened to me before.
Yeah.
They come to me to say, hey, this is great. You're doing great. We are going out to raise funding for you. How much money you need? They ask.
They get insights from the patient experience.
Yeah.
So that's a huge driver for a lot of these things. And you have some big donors that are part of that. Their child went to one of the children's hospitals and had an amazing experience. They want to support that so every kid's going to be along the way. I would love to say it happens every day. Unfortunately, we hustle to get our money. I think you can say the same. Everyone here can say the same. It's an endless hustle. Internally, our champions are child life specialists. That's internal with the hospital. We provide them with the education they need to do this well, so they have an understanding of how to assess the patient appropriately before putting a headset on, and even some of the technical components that they're afraid of. We educate them on that, so we have kind of a little thing there. You want to add, I'm sure.
No, I'm cool.
All right, it's cool. All right, cool.
I want to make sure people have a chance to ask questions.
All right, that's why you left? Okay, there you go. Peace out.
Gag order.
Yeah, all good. Any other thoughts about funding? It's a tough question. I hate funding.
So hard.
Yes.
With that, we talked about this 2 years ago, is standardization, right? And so as a businesswoman and as an inventor, one of the biggest challenges I've seen is how we can make VR in healthcare be adopted into policy. so like that's one of our programs right now is we're trying to get state legislation
Yes.
to actually include this
Yes.
into like whatever bills, like whatever medical. So I'm in
Absolutely.
telemedicine, so
Yes.
we're actually trying to augment asynchronous and synchronous technology with VR. So I just wanted to hear your thoughts as leaders and professionals, like because that's like the biggest barrier to entry. Is like, okay, let's get this covered by Medicaid, let's get this covered by the insurance panels, but also at the state and then there's the federal level because it's a whole branch, right?
Yep.
So I wanted to hear your thoughts on like everything that you're doing, which is so important. How can you take it to the next level to standardize the policy?
Well, yeah, one of the things we're funded by the Connecticut Department of Public Health to bring our VR marijuana vaping prevention into some schools and do some pilot testing. We're also funded by the Connecticut Department of Education because they have a bill now, right, about exploring VR in schools. It's like an actual bill, and so we've latched onto that to see what we can also learn. So I think sometimes and in all honesty, the Department of Public Health funding, you know how I got that? I emailed my state senator and I said, we've got this thing, it's innovative and it works and it's immersive. We bring the headsets, can we get some funding? And he called me back the next day and he's like, what can I do to help? And then he did. It took several months, but it was literally just a phone call. So look at your state fund. There's budgets there. There's calls all the time. You just need to send the emails, get people there are the people that are excited in your state about this and see it. And you just have to kind of put your neck out there and ask, right? And that's, so we're going to send a few letters. We saw a call. We got a few letters due this week, and one of them was like substance use prevention was the topic. And they were like, hey, send us anybody, it was an open call. Send us proposals up to $1.5 million of what you could do with this money for substance use prevention. Okay, we're going to bring our VR, intervention into schools. That's what we're going to ask. So look at, like, sometimes you can get these kind of, I think those policies are like, we didn't realize that there was like a bill passed around VR in schools. Yeah, so we're taking advantage of that. So I think that is kind of one way to kind of.
That's awesome.
Are there good sites to look at this, and where should we be looking first?
Every state's different, and at least my experience in Connecticut and talking to our local senator, their websites are a mess, and that's not Connecticut specific. So it's not easy. I think some of the best ways is just making personal connections with some state reps if you can. We're lucky we're in a small state, so a lot of times our state reps are literally our neighbors. But it's a challenge. I will say, despite the challenge, it's so much easier than NIH funding.
It was an email.
It was, yeah.
But it was also too a state senator kind of play on them too, right? In the sense of I think re-election year was that year. So they really wanted something innovative, and that was going to be in the schools. But also we were going to be in their communities. So as a state senator, it was 3 counties he oversaw. We were going to bring that to those schools, right? So in this case, it could be those hospitals or whatever. So kind of play into where they are also, because they want to do well because they want to get reelected. So they want to see some progress in their own communities. It's a game.
Nice.
Want to add anything?
No, I think they have good comments. I think, I'm an immigrant from another country. I did do enough sort of like a connection and communicate with other people. Recently, I found out even, just a nice email to the previous founder say, hey, 5 years later, I published this because you found this. And they really appreciate that. A lot of researchers forget about the previous founder and then do not communicate with them. So communicate with them, update them about what you're doing, and then, the future opportunity will come.
That's lovely. It is. I mean, we do that, but like that's lovely. See, I like that. That's a good take-home message. That's just kind. There you go. Any other questions? Yes. guessing we're all thinking in this capacity for sure. One of the things that I think everyone on this panel will think about is privacy and what we have to do to get through our IRBs to make that happen. I mean, I think it's interesting even with the VR headsets that, you know, they're capturing, a lot of them are capturing the eye movement there. That's a fingerprint of how these kids are moving. So privacy is something that we definitely would be considering, but the outcomes of adding those components is amazing, and you really could make that personalized medicine. I think you've talked about this a little bit.
Yeah, I mean, I think that it's the VR or any headset is a good conduit for clustering other metrics. I think that's what you're suggesting. And I know there was a keynote about this yesterday. The doctor's satchel going to the person's home can be filled with 25 or 30 different electronic devices, right, as they make their way to go do an evaluation. Some of this we could be getting via cellular or you know, mobile, whatever you want to say. But I definitely feel like VR could be in that package of data collection that would be important for precision medicine. It's just that it's the HIPAA stuff, right? I mean, my ITIS at my hospital is it's like death-defying to try to get through that system because they're so nervous about stuff being transmitted. So a lot of my VR tech is downloaded to the VR tech and not accessing the Wi-Fi signal because they're so worried about that, and they're also worried about ransomware, like creating holes in our security that people could crawl into. And so I kind of have to throw my hands up and say, yeah, we'll just do it. We'll just download it onto the headset. So we're missing out on all those fun little metrics that can be live, like API, et cetera. Maybe one day that will loosen a little bit, but other organizations are able to grab that real-time data, physiological data, which is exciting. And I think that, again, VR could lend itself to that whole package. You know, biosensors and all the wearables we learned about yesterday, wearable socks, wearable this, I was hysterical, right? I don't know if you watched that presentation, but it's true. There's a lot of data to be collected off of us to talk about our health. Like I wear an Aura ring, it collects all my temperature data, my sleep data, my activity data, you know, when I'm hungry, if I got COVID, you know, it's really terrific. So, but you know, this is all, and I signed up saying I'm okay with that, you know, I don't mind. So I think we're moving in that direction, and VR could definitely have a place on the shelf to do that work.
Also visualization of this data.
Yeah. Yeah, it's big data, right? Big
AI
data.
is going to be part of that, which is exciting. Yeah. AI definitely will be working through that. So we have about 3 minutes left. So I have a question for each of my panelists, which I end a podcast with, and I hate this question for myself. What do you want your legacy to be in this space?
My legacy?
Yes.
I don't know. I want people say this person made a significant impact on my life and
I love that. You're up, my friend.
Really?
Yeah,
Seriously?
I hate this question.
Yeah.
Go.
I love that she hates this question. You know, I was meeting with some people the other day and talking about the work I was doing, and they said to me, you're living your legacy. And I thought, wow, that's really profound, that we've actually changed clinical practice lines at the hospital because of VR. So I do feel like there's been impact, and I care the same, that you want to have impact and be relevant to the work that you do. And so that would make me happy.
That's fair.
Okay.
You're up.
I'm passing.
Want to go first?
It's a hard question, right?
It is such a hard question.
I know. I tricked you guys. I should have told you that, but meh.
Well, here's the thing, too, because when I get my little crying moments with Asher all the time, like, why are we doing this? I know nothing, especially when I get denied grants, right? I'm nobody. I'm never going to make it. This is nothing. I'm horrible. I'm useless. And then I get really frustrated, too, because, like, Asher's, like, doing the real stuff. He's, like, helping kids with brain cancer and families and his kids, and that's what he's doing. And I'm crying. I'm like, all I do is prevention. You're never going to see if it helped anybody. So
I'm selfish.
Like that's what he tells me. He goes,
I'm selfish. Like I want to see it.
Yeah. So I don't know my legacy because I don't think I'll see it until like way after I'm dead. Like
I don't think you would see it if you're dead. I'm just gonna. Okay.
I won't.
Well, so I think our goal for this center. Let's put it that way. Let's de-individualize
The legacy
it.
for the center. There you go.
We'll de-individualize.
Stepping
it a little
away.
bit. Yeah. I think is to make sure that these technologies have a place for kids. That kids have a seat at the table. That they are able to access these technologies for good, and we keep them safe while doing it. I don't want this to end up in a just say no situation where they never get access or they only get access when it's behind their parents' backs.
That's a good one.
Thank you. Thanks. I've been thinking about it.
My legacy is the same with the crying moments of not getting things and not being impactful. So I don't know if it's just, it's all good. Well, this is.
We were just telling our lab, if you're getting like 10% of the money you go after, you're doing really well.
I think it's interesting because, you know, NIH came out with a statement in 2021 that talked about whole person health, right? But we really don't do that. So, I mean, I think a legacy for all of us in healthcare, honestly, is if a patient can show up to a clinic or be hospitalized and really truly get whole person health, that would be amazing. You know, nutrition, lifestyle, pain management, care for their disease, all that kind of stuff, that'd be really incredible. And I think VR has a space in that because it can be preventive. Preventative ACEs, like we talked about before, adverse childhood experiences, educative, it can provide education about STIs and substance use and things. So it has a place, I think, for sure. So that's that would be the crown jewel. True whole person health.
I want to add a little bit on there. I want to be a sort of kind of like person who work together with other people to promote rigorous science and evidence for our field. So let's do that.
This has been a privilege to be up here with you guys. I honestly, that's why I know my friends say I overuse that word, but I really feel that. Well, it's genuine. So thank you so much. Thank you guys. You had fantastic questions. We appreciate you.